Welcome to the December 2024 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. My name is Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
As per usual, Alice and I will interview authors of the feature articles selected by the editorial board of Diabetes Care, followed by a rapid exchange segment where we discuss some of the articles we found particularly interesting.
Now, before we get started, can you believe it is December already, which is incredible? 2024 is coming to an end soon, and this has been quite the year in diabetes. What have been some of the big highlights for you in the past year, Mike?
Well, Alice, I've been really impressed by all the studies this past year evaluating diabetes technologies in populations not included in the original device approval trials. These have included CGM use in the hospital, which we'll hear about more in this episode, and automated insulin delivery use in pregnancy, to name a few examples.
Yep, those are great picks, Mike. And for me, some of the highlights of the year has been the expanding evidence around GLP-1 receptor agonists and dual GIP GLP-1 receptor agonists and diabetic kidney disease, heart failure, obstructive sleep apnea, and of course, in the obesity space. The other big one was the arrival of weekly basal insulin, which represents a new era in insulin therapy.
Yeah, Alice, there's certainly been a lot of progress in 2024, and we look forward to 2025 and the exciting developments to come. So, to wrap up this year, shall we dive into the December 2024 issue of Diabetes Care?
Let's do it. One of the feature articles from the December 2024 issue of Diabetes Care is a comprehensive review entitled Pathophysiology and Treatment of Prediabetes and Type 2 Diabetes in Youth by Dr. Fida Bacha and colleagues. I'm joined today by the first author, Dr. Fida Bacha, pediatric endocrinologist, professor of pediatrics, Baylor College of Medicine in Houston, Texas. Thank you very much for agreeing to be part of this podcast, and congratulations to you and your colleagues.
Thank you for the invitation to be with you today. It's my pleasure to participate in this podcast and discuss this work on behalf of my colleagues and highlight the importance of youth onset type 2 diabetes.
So, to set the stage, I'm going to start with perhaps a silly question, but I think an important one. Can you please share with our listeners what exactly do you mean by youth in this situation? And why do we need to pay particular attention to prediabetes and type 2 diabetes in youth?
So the word youth in our context refers to adolescents and young individuals, typically less than 18 years of age. But usually the adolescent age group as type 2 diabetes in children typically is diagnosed at mid-puberty. For example, the mean age of diagnosis was 14 years in this multi-center study called the Treatment Options of Type 2 Diabetes in Adolescents and Youth, or today's study. And why it is so important is that we have found in our studies that childhood onset type 2 diabetes is a different disease than that occurs in adults. And it is much more severe at presentation. It can progress very rapidly. Very early on in these children and youth, we see a whole host of cardiovascular disease risk factors early in their disease pathogenesis, and these tend to progress rapidly over time. So it's really important to distinguish it from adult onset diabetes and to really understand it better so that we can prevent this burden of disease in these children.
So, in the review, you do a beautiful job of discussing the critical components of the pathophysiology, including insulin resistance, beta cell dysfunction, and other hormonal and metabolic contributors. So, let's start with insulin resistance. Is there something unique about youth onset type 2 diabetes with respect to insulin resistance?
Yeah, a great question, actually, because we have found that insulin resistance in youth with pre-diabetes or type 2 diabetes is very profound. So, usually, as we go through puberty and as children go from pre-puberty to puberty, cross-sectional and longitudinal studies have shown there's about 25 to 30% reduction in insulin sensitivity. We call this physiologic insulin resistance of puberty. So when this is compounded by genetic risk for type 2 diabetes or with obesity, then that insulin resistance becomes very severe. And when we compared insulin resistance in youth with prediabetes or early onset type 2 diabetes versus that in adults with about similar adiposity and hemoglobin A1C, we could find that the insulin resistance in these children is about 50% worse than that in adults. So it's severely profound, and we believe that that also contributes to the response to therapy and why these children's diabetes is more severe.
Wow, 50%. That's quite a striking statistic. And I mean, puberty is always a challenging time in one's life anyway, but then compound that with the insulin resistance component. That's very interesting. Thank you for that. So then what about beta cell dysfunction then? What's unique about youth onset type 2 diabetes from a beta cell dysfunction perspective?
Again, so this greater insulin resistance in youth is hypothesized to exacerbate the insulin secretory demand on the beta cell. So there's initial hypersecretion of insulin, and then we believe that this greater insulin resistance in youth is hypothesized to exacerbate the insulin secretory demand on the beta cell with initial hypersecretion leading to eventual beta cell failure. And so beta cell dysfunction is manifest by reduction in insulin secretion relative to insulin sensitivity. And it's a central part to the onset and progression of prediabetes and type 2 diabetes. In the absence of this beta cell dysfunction, youth usually do not progress to diabetes. And the unique features in youth with type 2 is that by the time diabetes is manifest, this insulin secretion relative to insulin sensitivity that is usually described by what we call the disposition index is already severely compromised and is about 80% lower compared with peers of similar adiposity, sex, and pubertal stage who do not have diabetes. Another component of this insulin secretory problem is that the beta cell function declines rapidly in youth with type 2 diabetes. We estimated based on CLAMP studies and OGTT-derived indices that this decline is about 20 to 35% per year, compared with an estimated decline of 7 to 10% in adults. So that's another important factor as these children lose beta cell function rapidly, and this becomes a major determinant of glycemia and response to therapy. And we believe this profound beta cell dysfunction is responsible for the decrease in responsiveness to therapeutic interventions in children compared to that in adults.
Wow, so more insulin resistance and faster beta cell decline and more profound beta cell decline. So I could see why this is a very important topic for us to be aware of. And what are some of the other hormonal or metabolic contributors?
Several other hormonal factors contribute to the onset and progression of diabetes. The hormonal factors include hyperglucatonemia, which exacerbate the elevation in glucose, an incretin defect that we can detect also in children with prediabetes and type 2 diabetes, which also contributes to the insulin production deficit in response to glycemia. So you have all these hormonal issues contributing to the pathogenesis, but also contributing to lack of responsiveness to therapies. And other metabolic pathways that are involved, such as adipose tissue dysfunction, chronic inflammation, also contribute to the pathogenesis by promoting insulin resistance at the cellular level and also to defective insulin secretion. Mitochondrial dysfunction can also be involved, where we have a reduction in fatty acid oxidation, elevated reactive oxygen species, and lipid byproducts, which contribute to lipotoxicity, impaired insulin signaling, and defective insulin secretion. So, multiple factors do contribute to the pathogenesis and progression of the disease.
Now, beyond the biological contributors, though, how about the psychosocial and the social determinants of health? Can you please elaborate on how these components are critical as well in youth onset prediabetes and type 2 diabetes?
Yeah, this is a very important topic that we are starting to uncover. Most of these youth with type 2 diabetes come from families of racial and ethnic minority groups with low socioeconomic status and have a family history of diabetes. So the social determinants of health refer to the contribution of a lot of the environmental factor to the pathogenesis of a disease. And these families often experience multiple stressors, including food insecurity, unemployment, housing instability, difficulties with access to healthcare. These children may have been exposed to early adversity, which has been shown to affect health over time. So we're just starting to uncover as to how these social determinants of health may influence the risk for obesity and diabetes. And these are really important factors to pay attention to because they are potentially modifiable.
Absolutely. A critical conversation to have, right? And to have more research about. So now that you've beautifully told us about the pathophysiology and some of the unique features, now let's talk about treatment. So let's talk about comprehensive treatment, starting with the non-pharmacologic.
All right, so a lot needs to be done. And we believe that a multidisciplinary approach is needed to care for the child and adolescent with type 2 diabetes because there are so many factors involved in addition to the biologic factors. So at the presentation, type 2 diabetes can present in a severe form, like even having diabetic ketoacidosis. So we have to individualize the treatment depending on the presentation. But in terms of the non-pharmacologic, the mainstay of treatment continues to be lifestyle management because we really need to change the lifestyle behaviors for long-term success of dealing with this disease. And we continue to recommend adequate nutrition, reducing nutrient poor carbohydrate intake, minimizing consumption of refined grains and added sugars, elimination of sugary beverages. We also emphasize importance of physical activity and setting goals for gradual increase in physical activity, aiming to moderate to vigorous physical activity about 60 minutes per day would be great. But we focus on small goals and increase gradually, even like making progress in terms of reducing sedentary behaviors and increasing light physical activity will be conducive to improvements in metabolic health. Addressing sleep disruption is another important topic that we are now starting to understand better. In addition, it's important to assess and understand the context of including the potential food insecurity in the family, housing stability, etc., that we talked about as important social determinants, and addressing the psychosocial factors that these children often will have mental and behavioral health issues that if we do not address will eventually interfere with ability to adhere to therapy and engaging with the health professionals. So these are all issues that we need to be mindful of and involve a multidisciplinary team in the care of the patient and family.
And then how about from a pharmacologic treatment perspective?
Yes, so again, it depends on the presentation of the disease. And we have to address the metabolic dysfunction if these children present in severe diabetic ketoacidosis or hyperosmolar ketotic hyperglycemia. And we then have to use insulin early on to reverse these abnormalities. However, if children present incidentally and have lower A1C, then we still advocate for metformin therapy as a first-line agent because we found it to be effective in about 50% of these youth early on in treatment. So if they're responsive, the metformin is easy to use option and it has less side effects than some other therapeutics and can be utilized in the majority of these youth, at least in the short term. And then we assess responsiveness. So now that we have newer therapeutic agents that have proven efficacy in some clinical trials, we can consider them a bit earlier in the treatment algorithm and continue to keep in mind that some children and adolescents with type 2 diabetes will need insulin therapy depending on what stage of the disease they're at and this depending on the responsiveness to these other therapies. So we have now GLP-1 receptor agonists and SGLT2 inhibitors that are FDA approved for treatment of children and adolescents aged 12 and above with type 2 diabetes and can be used in the armamentarium to treat these conditions in children. keeping in mind that, the trials in children were relatively smaller than those in adults. The reduction in A1C with these treatments that were used in combination with metformin and lifestyle or metformin and insulin in a small proportion of children led to about a reduction of A1C compared to a placebo, about minus 0.8% to up to 1.4% in these trials. But unlike what we saw in adults with these agents, the effect on BMI was not great. And we didn't see significant improvement in a whole host of cardiovascular disease risk factors. So we still have to keep in mind that this is a different disease, and we hope that these treatments will facilitate therapy and improve outcomes, but we're still very early on in this process, and a lot more research needs to be done to really understand better how the effectiveness of these treatments in children will be and the long-term effects, because we really don't know. And it is, worth noting as well that the percentage of youth that were on insulin and were receiving these treatments in the clinical trial was small. So if we have more advanced disease, we really don't know how these therapeutics will be effective, but we hope that now physicians have more at their disposal to consider in the clinical management. And we still have to think that, yes, these children may need insulin, and we should be comfortable using insulin if we need it. So combination therapy may need to be considered. And we try to give some guideline to this pharmacological approach in our review that we hope will be useful to treating physicians. I would also like to emphasize the importance of paying attention to all the cardiovascular comorbidities that accompany type 2 diabetes and to address them and treat them, particularly lipid dysfunction, elevated blood pressure, microalbuminuria, and early nephropathy. And our review could not encompass everything, but we do allude to these and refer the readers to other sources for these algorithm and suggested therapies.
Now, you and your colleagues did a beautiful job of reviewing the pathophysiology, the treatment of prediabetes and type 2 diabetes in youth, stressing the importance of addressing it properly because the risk of complications is high. Certainly, the lifetime risk is quite elevated. But this then begs the question about prevention or delaying the onset for as long as possible. So, what does society need to do to address this issue?
Excellent question. So, in terms of prevention, we definitely need more research to understand which high risk children are going to develop type 2 diabetes and how to prevent these high risk children from progressing. So, we have now a longitudinal study that is funded by NIDDK trying to answer these questions. And it's going to be a multi center large study. So, we'll hope to learn more about who's at risk, understand how this disease progresses over the pubertal transition, and then to really focus on prevention a lot more. So now we still do not understand how to halt the deterioration of beta cell function in these children and adolescents. And the therapies that were available or applied in previous clinical trials were not as effective to prevent this decline in beta cell function. So a lot more research is needed in this space. In terms of as a societal levels, we really need to advocate for sweeping public health efforts to address the impact of health disparities, poverty, racism, access to safe neighborhoods, walkable cities, affordable and nutritious food. And we try to really emphasize these issues in our review because these are really important public health measures that are needed to prevent childhood obesity and as a result, prevent this progression to prediabetes and type 2 diabetes, the complications associated with this disease.
So, a lot for all of us to think about and a lot for all of us to do. So, thank you. Thank you very much, Dr. Fida Bacha, for sharing your expertise with us today. And congratulations again to you and your colleagues for this important review of a topic that can impact all of us. I encourage our listeners to read the full review in the December issue of Diabetes Care.
In the December 2024 issue of Diabetes Care is a feature article entitled Consensus Considerations and Good Practice Points for the use of continuous glucose monitoring systems in hospital settings. I'm delighted to welcome the article's lead author, Dr. Julie Shaw, together with co-authors, Dr. Jane Seley and Ms. Rebecca Longo. Dr. Shaw is head of the Division of Biochemistry and Point of Care Testing for the Eastern Ontario Regional Laboratory Association, an associate professor in the Department of Pathology and Laboratory Medicine at the University of Ottawa. Dr. Seley is clinical assistant professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at Weill Cornell Medicine in New York City. And Ms. Longo is an endocrinology nurse practitioner at Leahy Hospital and Medical Center and assistant professor of medicine at the University of Massachusetts campus in Burlington. I'm so glad you could all be here to discuss your article.
Thank you for having us.
Congratulations to you all and your colleagues on this feature article. I was super excited to see this topic selected, as Alice and I have covered a number of studies on this podcast series evaluating the use of continuous glucose monitoring in the hospital setting. And I've shared my fantasy on a number of occasions for the day when our hospitalized patients' sensor glucose data will be accessible to care providers as cardiac telemetry. Now, I'm curious as to what prompted your writing group to come together on this topic, and how did you go about building consensus for your report?
So, yeah, thanks for that question. I took the lead in pulling these groups together, and I was really prompted by a talk that I attended at the ADLM meeting, which is the Association of Diagnostics and Lab Medicine, formerly the AACC. A few years ago, there was a talk on CGM when I was attending the meeting, and it got me thinking about, as laboratorians, how I think we need to address this and we need to get ahead of it. As a lab director, and in particular as a director of point of care testing, I regularly receive queries from clinicians on whether patients can use our CGM while they're in hospital, because patients are asking for this. And can it be used for clinical decision making? And so I thought it was an important topic to address. And I think that the lab needs to be involved in helping to develop guidelines, and we need to work really collaboratively with our clinical colleagues to help to bring this into the hospital. And I think it's important that we address it and figure out how to do it, not, no, we can't do that. And so that's what prompted bringing together, lab professionals from Canada, lab professionals from the United States, lab professionals from international groups as well, and then together with the American Diabetes Association as well as Diabetes Canada to kind of, bring that all together. And as far as developing consensus, I mean, we worked on this article for a couple of years, regular meetings, a lot of discussion on coming to consensus for this.
And when I got the call from Julie, did I want to help her with this project? The inpatient setting is my hood, and people come in wearing CGMs and they don't want us to take them off. And we had no guidance because it wasn't approved for that use. There was nothing. People were writing policies at hospitals across the nation and everywhere in the world, but we had no information about it. So this was like an amazing opportunity to do something that was missing. So thank you, Julie.
Yeah, and Julie, that's super interesting what you said about bringing the perspective of the hospital laboratory into the discussion, because I agree. I think as a provider, and Jane can attest to this, we think a lot about whether it's the provider or nurse patient interaction surrounding CGM in the hospital, and not the importance of how to validate the use of a point of care test to make clinical decision meetings, even if that clinical decision is to go use your hospital point of care glucometer to check the individual's glucose. Now, your article makes a distinction between continuous glucose monitoring or CGM devices that are patient owned, which we've been talking about, but also those that could be hospital owned. And I'm super interested on where we might be going with that idea. And so, what is important about making this distinction, and how should each source of device be treated for our hospitalized patients? And starting with you, Jane.
Well, it's an important question because in the US alone, there's well over 3 million people that are wearing CGMs in the wild. So they come into the hospital and it's like asking people to take their dentures away to take their CGM. They don't want to do it. So we need to support them in safe and effective use of CGM in the hospital. And what that means is they can wear it and they could use it for sort of an early warning system that lets us know that their glucose is suddenly rising rapidly or falling rapidly. But we must use the point of care device, as Julie regulates very well. We thank the lab people for their guidance in this, for dosing insulin and for anything related to identifying and treating hypoglycemia. But we can utilize the information to know that something's impending and prevent it. So that's amazing.
Now, similar to telehealth, implementation of inpatient CGM benefited from the COVID-19 pandemic that really shift the perceived risk versus benefit balance over using remote monitoring to using technologies that already existed and could be implemented. But while since the end of the pandemic, telehealth appears here to stay, what do we need to get authorization for CGM to continue to be used for hospitalized patients in the post pandemic era?
Yeah, it's a good question. I think we need more data to better understand, for example, interferences and, for example, what medications might interfere, what physiological conditions might not be conducive to use in certain patient populations. We had similar questions about point of care glucose meters, right? We had to validate those in critically ill populations. There's some populations and physiological conditions where you can't use them. There are certain interferences that prevent us from using the point of care glucose meters that we all use today in certain populations. I think the same questions are there for CGM, and we need to better understand where can we use them safely and where can we not use them safely. And going back to your earlier question, I think in my mind, the ideal situation would be that we would have a hospital grade CGM. And then when the patient comes in, we can use that and we'll know, just like we know with the glucose meters, what are the interferences, because we'll have robustly validated those in the hospital setting, just like we have with point of care glucose meters. I see that is really needed, and then we can use them safely, and that would help with training, because everybody would be using the same thing. We would know about it. It would help with connectivity, because we wouldn't be trying to connect all these different type of CGMs, but there'd be one that you could connect in with your electronic health record. So to me, that's the future, and that's where we need to get. But really, regardless of the meter, we need to understand what are those interferences, what patient populations is this safe for, and what patient populations is it not.
Julie, I love that advocacy for the hospital CGM device, and the analogy to what we've done with point of care finger stick blood glucose monitoring is so apt to apply. And so, to your point about what populations and validating the systems, I'm going to turn to you now, Rebecca. Your article reviews a number of studies from various inpatient settings documenting benefits derived from the use of CGM. Can you highlight a few populations to consider a top priority for implementing inpatient CGM that could use the hospital system, and what the expected benefits would be?
Well, first and foremost, people at risk for hypoglycemia. We know that hypoglycemia in the hospital is very dangerous, it's costly, and we've seen that CGM can reduce the rates of hypoglycemia. So, certainly for that high risk population, the CGM would be very beneficial. There's also individuals who require frequent glucose monitoring to maintain tight glucose control, like those who are critically ill or in the operating room. And there's been some nice hybrid point of care CGM models that have worked very nicely in this population. Lastly, I would highlight the diabetes and pregnancy population. So, CGM is now approved for use in pregnancy in the outpatient setting here in the US. And so, as folks come through into the hospital, and particularly during labor and delivery, maintaining those tight glucose levels is just absolutely critical. Then, moving to postpartum, insulin needs drop dramatically and glucose levels will fluctuate quite dramatically. And CGM can be beneficial for hypoglycemia detection as well as facilitating the necessary insulin adjustments during those periods.
So that's super great, Rebecca. And as we implement, I hope, the standard use of CGM in hospitalized settings, as you alluded to, Julie, the care in ensuring the validity of the measurements must be ensured. And so I'm curious if you could just expand a bit on what guidance there is about ensuring validity. How should we approach validating CGM glucose data in the hospital? And what are potential interferences that providers should keep in mind?
Sure. I mean, I think it's key, firstly, to assess the clinical and the analytical performance of specific devices. And we allude to this in the paper. We talk a lot about what does that look like, because we need to understand the limitations in the local patient population. And so I think, doing comparison studies with the local lab to understand where there are differences and in which patient populations is going to be really important. You need to understand, and have local protocols for how to deal with the sensor equilibration period, for example, and have guidance for how often do you need to do a parallel point of care test and for how long, and what's the level of agreement that needs to be achieved before you can stop doing that parallel testing and move to the CGMs. And those protocols need to be in place. We need to understand the interferences so that patients who potentially on, for example, a medication that might interfere can be excluded from CGM use, at least for the period of time that they're on that particular medication. Interferences will likely vary by CGM manufacturer, similar to what we see with the point of care glucose meter. So you need to understand the interferences specific to the meter that's being used, which is why I think having sort of a hospital grade meter that is in place in a hospital would be great, because then you would know all that information and you would have the data locally. So that the manufacturers usually do these studies, and they should be included in the instructions for use for the CGM meter. They should have done some of these studies, but they may need to be done locally if they haven't. Some common interferences are actually quite similar to what we see with glucose meters. Acetaminophen, hydroxyurea, mannitol, tetracycline, salicylate, ascorbic acid. Those are some of the common ones, but again, it will vary by CGM. And then I think it's important to work with the lab to sort of develop thresholds over which, if it's glucose is over a certain concentration, you need to do a confirmatory test with the lab, or below a certain concentration. And I think, that you can work with the lab, to figure out what are those thresholds, and work with the clinicians to figure out, well, when do we want to do this to be safe? So yeah, and I think we need clear guidance as to when CGM cannot be used. For example, certain procedures, they have to be removed, certain imaging procedures. And so it's just really important that all these protocols be laid out in the hospital setting so that everybody is using the CGM in the same way.
And so clearly, use of CGM will hopefully limit the number of finger stick blood glucoses that a patient and a nurse and a medical assistant all have to deal with obtaining and documenting. But there will clearly be the need for patients on CGM to have that finger stick blood glucose confirmation for, you mentioned, in parallel while you're documenting the accuracy of the sensor glucose. And at times when guidelines say above or below a certain threshold, a confirmatory finger stick glucose is required. So having the sensor glucose data and the finger stick glucose data in the same place would be really nice, I think. And so, coming back to the point I brought up earlier about telehealth, which now our electronic medical record, or EHR, and the one of my institution is Epic. So since the pandemic, Epic now has its own telehealth platform. So if you're doing a telehealth visit, you're in the same system as you are for all of your other clinical documentation. And now with CGM, we still are forced to log into multiple platforms, as you mentioned, Julie, depending on the manufacturer, and in order to access the data that we're then, copy pasting into the EHR or directly keying in. And we know that that's all susceptible to delay and errors, and really is not what best practice is. So what will it take to get the CGM data integrated into the EHR? And will, this potential for use in hospital help to push this alignment?
Yeah, I could not agree more with you. Our current system is far from ideal. In terms of in the hospital where CGM is being used, nurses have to manually enter each individual CGM value into the EHR. And these values are not always displayed in a standardized manner. Sometimes there are comments, sometimes they're only displayed in the medication administration record. And so clinicians may have difficulty reviewing the CGM values, or even differentiating what is a CGM value versus what is a blood glucose value.
To take that a little further, all of this is getting better and better. So Libre has had a way of giving us integration into Epic, for example. I don't know about other EHRs because that's what we have. And they don't charge for it. So we're in the process of integration now. We were supposed to go live for my birthday on June 13th, but it may be my half birthday when we go live. But we will be able to have it pushed right into the electronic health record anytime we want it. October 15th was a very important Dexcom day for me because at a diabetes technology meeting, the medical director of Dexcom announced that they also would have interoperability available for free into Epic. So we're in the process of negotiating that now. So we'll be able to have the two main CGMs that people come into the hospital wearing with the data available to us. So that's an amazing change. And Epic is also working on it, by the way, as an electronic health record. They're working very hard to get this to us soon. And I believe they will be able to accomplish that as well. So you'll also be able to get it directly from Epic.
Well, Jane, that is really welcome news. As Rebecca pointed out, that is, such a critical hurdle to get over in order for our best practice and most efficient use of this information for our nurses, providers, helping our patients to get the best possible outcomes from their hospitalizations. Do you have any final takeaway messages for our listeners?
I wanted to bring something up which you didn't ask, but is really dear to my heart. I think it's a really great opportunity when someone's in the hospital and they come in and their A1C is very high, or they have hypoglycemia, or they're going home on complicated insulin plans that they haven't done before, to send them home wearing a CGM. And more hospitals are doing this, and both Abbott and Dexcom are supporting us doing this. So we have the capability now to put the CGM on a day or two before discharge, teach them how to put it on, how to take it off, how to work the app, all while they're still in the hospital, and help them respond to the trend arrows and learn in real time how to do it. The only caveat is, because the device is not approved right now to use the data in the hospital, they would have to call the nurse, and they're taught that. If they're wearing a personal CGM throughout the stay, they're taught, call the nurse when you think you're low, you think you're high, so we can verify it. But this is going to open up the world to CGM to so many more people, and I think it's welcome.
I'll add, I think it's important to keep in mind that the value of CGM in the hospital is not just in the replacement of finger sticks. The hypoglycemia, the hyperglycemia detection is incredibly valuable, particularly in the hypoglycemic range. And the ability to review trends in real time may actually help to overcome many of the logistical challenges that we have in the hospital right now, such as ensuring that pre-meal glucose values are checked, or optimal escalation and de-escalation of insulin doses, particularly as a patient's clinical status and nutritional trends change.
Yeah, I would just add that I think, we need to work together, the clinicians, the IT in the hospital, because we didn't touch on that, but that's also a big group that needs to be involved in this, especially when we're talking about connectivity, and the lab. And I think, if we can work collaboratively, we can come up with protocols that will allow for safe and effective use for these meters in the hospital. And I think we can take a lot of the lessons we've learned from point of care testing. I mean, we've had a lot of the same challenges, right? Where are the results? They weren't in the electronic health record for a long time either, and now they are. And so I think we can take some of those lessons learned and work collaboratively to make this work.
And I think the most important thing is, when you think about, all we knew was 4 moments in time in the day for most patients. Now we know 24/7. So when I'm adjusting a basal insulin dose, I can see everything that went on during that 24-hour period that basal insulin worked or didn't work. And I know exactly what I'm doing. And I can see that, oops, they had some kind of big dinner or takeout somebody brought them, and that's why they went high later, and so on. We learned so much amazing discoveries by having the availability of data every 1 to 5 minutes.
Dr. Julie Shaw, Dr. Jane Seley, Ms. Rebecca Longo, thank you so much for sharing your expertise with us today. I really appreciate all I've learned from your paper and our discussion on the use of continuous glucose monitoring systems in hospital settings. And I really want to encourage our listeners to access the full article in the December issue of Diabetes Care.
The cover of the December 2024 issue of Diabetes Care features artwork using oil pastels by Dr. Hannah Wesley, a dentist, an epidemiologist, and a public health scientist at the Madras Diabetes Research Foundation, and recently earned her doctorate from Deakin University in Melbourne, Australia, with her thesis focusing on the epidemiology of early pregnancy gestational diabetes in South India. Congratulations to you, Hannah, and thank you so much for joining me today and agreeing to be part of this podcast.
Thank you for your kind introduction and for having me on this podcast. I'm truly honored to have my artwork featured on the cover of the Diabetes Care Journal, which actually blends my passion for science and art. My heartfelt thanks to Professor David Simmons, the principal investigator of the Toboggan trial, for this amazing opportunity.
So once again, congratulations to you for having your artwork featured. And before we actually discuss the specific striking image that you selected, share with us a bit about yourself and your professional research journey. Because I have to say, when I read dentist to start, I was a little surprised that you ended up as a diabetes researcher, but very grateful that you did. And how has art fit into that journey?
Well, I practiced dentistry before pursuing a postgraduate degree in epidemiology and public health from Christian Medical College, Baylor. As a new mother, just returning from her career break, I joined the Madras Diabetes Research Foundation, also known as MDRF, where I started my work on gestational diabetes. I'm grateful to Dr. V. Mohan and Dr. R. M. Anjana at MDRF for their incredible guidance and support through my doctoral candidature with the Deakin University. During this time, I was also actively involved in implementing the Toboggan trial at MDRF, Chennai. On the other hand, creativity has been a constant in my life. Writing has been one outlet, and visual art has been the other. Even during my school days, I loved sketching small cartoons in the margins of my textbooks. So, being a self taught artist, I enjoyed exploring different mediums like pencil, paint, pastels. So, using art as a way of centering myself amidst the chaos of everyday life was my favorite pastime, I would say. So, that's how I've ended up here on the cover of the Diabetes Care Journal.
Well, we're again grateful that you took this journey, and the featured art for the December issue cover is entitled Embodiment of Motherhood. Please tell us about this piece and what it means.
So while my artwork usually portrays landscapes, for this latest issue of Diabetes Care, I drew the inspiration from my own experience as a mother. As we know, pregnancy, I feel, is a bit of potpourri. It is a blessing, but it can also be challenging at times. Initially, I started this piece as a sketch, but eventually chose to work with oil pastels, which is a medium which I recently nurtured and refined. Through the mending of various shades of blue, I sought to illustrate the complexities of pregnancy. To me, the blues represent the changes a woman undergoes during this journey, from shades of bright and joyful, while other shades are dull and muted, reflecting the endocrine milieu and the emotional spectrum the women have to navigate before finally holding their baby. Despite these blues, a woman baptizes herself as a mother. The bond of love is symbolized in how she cradles the baby in her womb. This is the baby who transforms these blues into a thing of uncomplicated beauty. And this bond will grow stronger and blossom brighter in the years to come. This artwork, the embodiment of motherhood, comprises of all of these.
Beautiful. I always take such pleasure listening to artists as they describe their piece and what it means to them. So that was beautiful. Thank you. And what inspired you to submit this particular piece to Diabetes Care?
To talk about inspiration, I believe we all are small pieces of a larger puzzle, intricately and beautifully woven together by the grand weaver. With each small piece that falls into place, the picture comes clearer, evolving into a masterpiece beyond our comprehension. And I believe this artwork on diabetes care is one such piece. So let me explain. One fine evening, I received a call from Dr. V. Mohan regarding an exciting opportunity. Professor David Simmons had mentioned this idea of submitting an artwork for the cover of Diabetes Care special issue on the Toboggan study. Seeing this as a unique chance to combine my creativity with my research background, I eagerly embraced this opportunity. Drawing inspiration from my previous work, I crafted this artwork, a visual representation of my dedication to science and art and all the participants of the toboggan study.
Wonderful. And finally, what would you say to anyone listening to us now who's thinking about submitting their art to be considered for a cover of Diabetes Care?
To anyone considering submitting their art to the cover of Diabetes Care, I would say go for it. Art has a unique way of communicating ideas and emotions that science alone can't express. So, if you're passionate about blending creativity with your scientific journey, this is a wonderful opportunity to showcase your perspective. Don't hesitate, your work could inspire others and offer a fresh lens through which to view important scientific topics. Trust your vision and share it.
Wise words, Hannah. So thank you so much, Hannah, for sharing your time and your talent with us. And for anyone listening who has original art they wish to submit, remember the words that Hannah just shared with us. Please email the ADA at productionmanager@diabetes.org or visit the Diabetes Care website for more information.
Let's move on now to our rapid exchange segment where Alice and I chat about some of the articles we found particularly interesting this month. Alice, what is your first pick?
Well, Mike, my first pick is a small but mighty study from Brazil that has important global implications. Although it is recommended to change insulin needles often, it may not be realistic for everyone due to cost considerations. Dr. Gabriela Berlanda and colleagues from Porto Alegre, Brazil, sought to determine the clinical and laboratory differences of reusing or not reusing syringes and needles for insulin administration. 71 adults with type 2 diabetes were randomly assigned to not reuse or to reuse insulin syringes and needles 5 times. The primary outcomes were glycemic control, pain scores, and skin complications, including ecchymoses, lipohypertrophy, nodules, and infection, at baseline, 4, 8, and 12 weeks. Interestingly, the group that reused syringes and needles had more lipohypertrophy or nodules, but did not experience worsening pain or glycemic control. And in fact, the reuse group had greater increase in treatment adherence. There was no difference in overall skin complications, quality of life, or infections. So, although the recommendation should still stand for insulin needles and syringes to be changed regularly, when reuse is required, and the reality is sometimes it will be, the negative impact is not as great as perhaps we would have thought.
And I think many of our patients would attest to that as well, Alice. And although more important perhaps may be to avoid reuse of injection sites that can contribute to the development of lipohypertrophy and nodules forming that can impact insulin absorption. My first pick examines the association of insulin resistance with cardiovascular disease and all-cause mortality in type 1 diabetes. Insulin resistance in type 1 diabetes is often ignored since the primary defect is the loss of insulin secretion from beta cells destroyed by islet autoimmunity. But the peripheral rather than portal delivery of pharmacologic insulin replacement requires systemic hyperinsulinemia to restrain hepatic glucose production that, together with periods of hyperglycemia, contribute to the insulin resistance of type 1 diabetes. Dr. Rui Sun from Beijing University of Chinese Medicine and colleagues conducted a systematic review and meta-analysis of 8 studies involving over 21,000 individuals with type 1 diabetes, followed for a median 10 years, and found that greater insulin sensitivity, measured as the estimated glucose disposal rate, was associated with significantly reduced risk of both incident cardiovascular disease and all-cause mortality. So strategies to improve insulin sensitivity should be considered for type 1 diabetes as they are for type 2 diabetes.
And I think it's a great reminder for all of us because just because someone happens to live with type 1 diabetes does not mean that they will not get something like overweight or obesity, which we know can certainly contribute to insulin resistance, right? So I think being aware that people can also have other things go on beyond their type 1 diabetes. And I think the interest in adjunct therapy in type 1 diabetes is also really surging. So fits in very nicely with that movement. So my second pick is also a little bit off the beaten path. It's actually about plantar electrical stimulation, which is a non invasive treatment that delivers high frequency electrical currents to the lower extremities to stimulate sensory and motor neurons. Prior studies have shown improvements in postural control, balance, gait, and reduction in pain. Dr. Myunggan Lee and colleagues from UCLA, Baylor College of Medicine in the United States, as well as the Hamad Medical Corporation in Doha, Qatar, sought to determine if applying this technology during dialysis sessions among people with diabetes and chronic kidney disease would result in any meaningful changes. 117 participants were randomized to receive 1 hour of intradialytic plantar electrical stimulation sessions 3 times a week for 12 weeks or a sham device. After 12 weeks, the intervention group had better gait performance measured as stride time at dual task and fast walking, better physical activity, which was the stand to walk and sit to stand time, as well as better quality of life, less plantar numbness, and better cognitive function. The intervention group also reported higher usefulness and usage satisfaction with greater willingness to continue to use the system. This represents a feasible, low-risk therapy option that can be used while one is sitting there anyway, getting dialysis, which can then result in better mobility.
That is super interesting, Alice. And to me, seems like the first treatment for diabetic neuropathy that addresses more than just pain and can actually help to improve functioning. So that's really, really terrific. Now, something else we all need to function is a good night's sleep. My next pick comes from Dr. Jean-Philippe Chapeau at the Children's Hospital of Eastern Ontario Research Institute in Ottawa, and colleagues who examined accelerometry data from over 73,000 adults followed prospectively for 8 years in the UK Biobank, and found sleep irregularity was associated with increased risk of developing type 2 diabetes, an effect that was independent of sleep duration. So this tells us that maintaining a consistent sleep schedule, in addition to meeting sleep duration recommendations, can add to protection from future diabetes.
And I think this study sort of adds to the existing literature around the importance of sleep. So, sleep duration, sleep quality, and then now consistency as well. And I mean, we all hear about these studies. And just sadly, none of us are following the advice, but we should. And maybe, New Year's coming. Maybe this will be a New Year resolution for myself that I'll actually pay attention to this. So, my last pick addresses the ongoing question about the use of SGLT2 inhibitors in hospital. It's been really fun to watch the evidence pendulum swing from absolutely never use in the hospital when one is sick to the other side of maybe it has beneficial properties even in the hospital. So in this issue, Dr. Frank Gow and colleagues, with the senior author of Professor Elif Ekinci at the University of Melbourne, performed a systematic review and meta-analysis assessing the safety and efficacy of SGLT2 inhibitor use in hospital. 23 randomized controlled trials comprising 19,846 participants, 29.5% of whom had type 2 diabetes, compared SGLT2 inhibitor to placebo or active comparator. Ketoacidosis rates were numerically higher in the SGLT2 inhibitor group, 0.21 per 100 person years, compared to 0.14 per 100 person years with control. However, this was not a statistically significant difference as the numbers were very low. Importantly, though, SGLT2 inhibitor use was associated with lower readmission and urgent visit and mortality in the heart failure studies and lower acute kidney injury overall. The authors appropriately point out that although the ketoacidosis difference was not statistically significant, that may have been a function of the very small numbers. It would seem that there is a real association, but the absolute risk is low, and then it's a matter of judgment, I guess, as to whether the benefits may outweigh the risks.
Yeah, and to arrive at that sweet spot where we're not restricting use of these agents in the many who can benefit, but still avoiding the serious consequence of ketoacidosis in the few that do. We really need studies now developing prediction models to help us identify those at greatest risk. My last pick comes from Dr. Eric Renard from Montpellier University Hospital in France and colleagues from the OP5003 research group, who conducted a randomized clinical trial of 13 weeks treatment with the Omnipod 5 automated insulin delivery system compared to standard sensor augmented pump therapy in 194 individuals with type 1 diabetes not achieving glycemic targets. So hemoglobin A1C in this cohort ranged from 7 to 11%, with the mean at baseline being 8.5%, which is more representative of the real world population with type 1 diabetes than cohorts investigated in earlier trials of the Omnipod 5 system. In the present study, automated insulin delivery led to a 17.5 percentage point increase in time spent in the normal glucose range of 70 to 180 milligrams per deciliter and 0.6 percentage point reduction in hemoglobin A1C. These data support the benefit of automated insulin delivery for glycemic control, even among individuals across a higher range of starting hemoglobin A1C values, but do also highlight the additional work needed to achieve recommended targets of spending more than 70% time in range and less than 7% hemoglobin A1C for the majority of those with type 1 diabetes.
And I think that more and more we get data like these looking at automated insulin delivery, the old paradigm of having a quote unquote good patient who should be on automated insulin delivery and based on A1C and based on their level of engagement, et cetera. I think those are old models of thinking and we should stop being gatekeepers. And I think we're seeing more and more data showing that these systems are changing the game, right? And therefore, we really ought to be allowing these opportunities for more and more people. Well, this brings us to the end of this issue of Diabetes Care on Air and our last episode of 2024. So, big thank you to Dr. Fida Bacha, Dr. Julie Shaw, Dr. Jane Seley, Ms. Rebecca Longo, and Dr. Hannah Wesley for sharing their expertise with us.
And a big thank you to our listeners for your incredible support over the past couple of years. Please tell your friends and colleagues so that we can continue to grow the diabetes community voice. Remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. And thank you for listening.